Pediatric Medicine Fellowship at Penn State College of Medicine. In addition to her clinical work, she serves as General Secretary of AMMA USA and Sahat Ijasmani Secretary for her local chapter.
Jazakallah for that introduction. I'm going to be talking about the most important organ for optimal longevity and for a long and functional life. Um, I'm sure, next slide, and next slide. So I'm sure many of you did not think of the muscle tissue as the answer to that question. It is something that is often overlooked, even in our annual physicals with our doctors, unless we show signs of muscle weakness. In fact, many of us associate muscle strengthening or weight training with professional athletes or bodybuilding. A lot of the women think that if we lift weights, we will end up looking like her or him or him. Um, but in fact, the truth is that you can be any of these shapes and sizes. Next slide. You can be any of these shapes and sizes and still can have good strength. Being fat or skinny does not mean that you have or don't have healthy muscle. Actually, there are a lot of women who may be obese with health issues, but because they work on their strength, they have better chances of leading more functional lives later on than someone who only does cardio or walking. When we talk about, Muhtaji ki zindagi or life of dependence, muscle health is at the top of the list to work on to prevent that Muhtaji ki zindagi. Um, next. So this lady is considered obese in, whatever culture you're from, yet she is able to stand on her hands, balance herself, and reach out behind her with her leg because she has worked on her strength in different ways, which is what we need to do to stay and continue to be healthy and functional and not be debilitated in our 80s. Just out of curiosity, how many of you think you are strong enough to hold that pose? So starting in our 30s, we lose about 3 to 8% of muscle per decade, which speeds up with aging, especially after menopause due to hormonal changes and whatnot. We often don't notice it early when small acts requiring us to be strong become harder, like walking for too long or climbing or even doing sajda for too long on the ground, getting up from sajda or standing back up after namaz, or feeling unsteady while carrying groceries or laundry up and down the stairs. We chalk it up to old age catching up to us, but by then, significant muscle has already been lost. Recent research has drastically changed our opinion on what muscle health means. Multiple studies show that in older women, muscle strength is linked directly to survival, not just functionality, but actual mortality risk. In fact, in these studies, strength could predict longevity better than body weight or BMI. Even something as simple as good grip strength or ability to stand up from a chair without help has been shown to correlate with better overall health and lifespan. Next slide. So, what does the muscle actually do for our health other than just give us strength? It plays a major role in glucose storage and glucose balance in our body. When muscles contract, they pull sugar out of the bloodstream and use it for energy, and it is all without insulin. So, strength training or weightlifting is one of the most natural ways to prevent or reverse diabetes. Of course, along with medications if your doctor has prescribed them for you. Muscles also play a major role in controlling blood pressure. When muscles contract, they help pump blood through the veins back to the heart, which improves circulation and blood vessel flexibility and reduces pressure in the vascular system. Um, Improved strength also prevents falls, which seems like a no brainer, but honestly, weaker muscles actually lead to slower reactions, and that increases risk of fractures when you fall because you're not able to brace yourself against the impact, which can lead to hospitalizations and long term disability, which could have been prevented to begin with. We often think that the brain and muscle are separate, but they're very deeply connected. Studies have shown that weight training actually protected parts of the brain associated with memory. That weight training twice a week may protect against and improve dementia. That better leg strength specifically was associated with better brain structure and slower decline of cognition over a decade. Not just that, if you have arthritis, strengthening the muscles around that joint will actually help you stabilize it better and ease the pain and inflammation and help us be more functional later on in lives. So muscle is actually a form of, medicine built right into our body that you just have to kind of tap into to prevent and manage a lot of the major health problems. Next slide. With all that doom and gloom, it's encouraging to know that muscle can be rebuilt at any age. Anyone, even if in their 70s and beyond, although it can be a much harder road at that point, can rebuild strength. There are two things that help with this. Number one is exercise, which helps stimulate the muscle, and number two is protein, which helps build and repair the muscle. Um, Next slide. So let's talk about exercise first because it's something that we're all kind of familiar with. Building strength does not require an expensive gym membership or complicated routines or a personal trainer. A good routine of 3 to 4 times per week for 20 to 30 minutes can do the trick. You can start off by just simple exercises like chair squats, wall push ups, light resistance bands, light weights, and movement with them, just 2 to 5 pounds at a time. Something as simple as stair climbing 10 times in a row can be a good starting point. It may take you like 3 to 5 minutes, but you'll notice the difference in your leg muscles within a week, and then you can improve it afterwards to do more or less as you go along. Again, consistency is key, so doing something small every day is more important than having complicated exercise plans. Not all muscles are equally important for daily life. The most critical ones are leg, hip, core, and back muscles. All of them together help you stand, walk, and climb stairs and stabilize your body for better balance, as well as protect your spine for better posture and prevent your stooping. If you focus on these areas, you get the greatest benefit for function and independence later on in life. Arm and shoulder muscles, they're not vital, but they are still very important because they are your second line of defense after your hips, core, and back. So, for example, if I stumble and my hips and core are not able to get me, to regain my balance, then I would have to depend on my arms and my shoulders to catch my fall and not smash my head or hip on the floor, which is very important. Next slide. So now let's talk about protein. Where exercise stimulates the muscle and strengthens it, it is actually protein that builds the muscle. Without enough protein, your body cannot repair or grow muscle tissue effectively. As we age, we need more protein, not less. Many of us, especially the older we get, we unintentionally underconsume protein, which accelerates muscle loss. So keep that in mind while having dinner tonight. Next slide. So how much do we actually need? The traditional recommendation is zero point 0.8 grams per kilogram per day. This is actually the minimum to avoid deficiency and maintain the muscle that you currently have. This is not the optimal amount to gain muscle. For people over 50, research now supports that it's actually 1 to 1.2 grams per kilogram per day that's needed. If you're exercising, it's closer to 1.2 to 1.5 grams per kilogram per day. So, for example, a 65-year-old who weighs about 70 kilos needs about 70 to 90 grams of protein daily to maintain muscle. Also important, protein should be spread throughout the day and not just compacted in one meal. Next slide. So these numbers, they can give you a realistic sense of how much protein we are actually getting when we eat each of these foods. For example, you can see that that 100 grams of chicken breast gives you about 30 grams of protein, which is an excellent source. It's lean. But 100 grams of lentils only gives you about 9 grams. So it's still very healthy because lentils have a lot of vitamins and minerals. But you need a much larger portion to meet your protein goals for them. So you do need to combine them with something else. Also remember that nuts, seeds, and dairy, like Greek yogurt, and don't be mad, the cottage cheese, they can also augment your diet for protein's sake. The goal again is not memorization, not to complicate things. It's just awareness. So once you understand what foods go well together and what you can eat to get your meet your daily targets, it gets a lot easier. Next slide. Some foods, like processed meats, may provide protein, but they also come with a lot of sodium and preservatives, so they're not really the ideal choice. Protein powders can be helpful, but they are supplements. They're not replacements for real food, so they can be useful when your appetite is low or schedules are busy. So just look for something that is low in sugar and it has minimal ingredients and additives. So, sorry, the slide before that. Thank you. Creatine is one of the most well-researched supplements. It helps increase muscle strength, improve exercise performance, support energy in muscle cells, and support brain function. Emerging research also suggests that it benefits the brain function while aging. For women, especially over 50, creatine can be a very good addition when combined with exercise. So, and then the typical dose is 3 to 5 grams per day. You should consult a physician first before taking, especially if you have liver or kidney disease. A lot of creatine nowadays is coming with additives that cause your muscles to swell because when bodybuilders, when they want to build muscle, it's a lot of it is water. Increasing the recommended amount or taking too much is than what your body can handle can be harmful. So make sure you're not exceeding the daily dose, and there's no additives to it. Next slide. So key takeaways. The goal is not to look skinnier. It is to stay stronger for a longer part of our lives. Muscle health is very important if you want to live independently and with the best health for a longer part of your life. It depends on two things. Again, it's exercise and protein. Without both, results are limited. Choose healthier options. You don't need perfection, just consistency. Jazakallah.
Jazakumullah. I will be introducing our second speaker, Dr. Mateen Malik. She will be speaking on a new vision for elderly care. Dr. Malik earned her medical degree from King Edward Medical University in Pakistan and completed her family medicine residency at the University of Texas Southwestern. After years of serving underserved populations as a primary care physician in Texas and Virginia, she completed fellowships in geriatric medicine and hospice and palliative medicine at George Washington University. She currently serves as an associate hospice medical director.
Assalamu alaikum. Jazakallah for that introduction. Next slide, please. So, oh, Jazakallah. So I'm going to talk about a topic a little bit more grim that my co-presenter was talking about. I work in hospice. I deal with end of life. And what I have seen in the last couple of years working in this field is that there is not much awareness about dementia and the final phase of life in patients with dementia. We are not equipped with how to deal with that phase. Islam prepares us for every phase of our life, right? We are asked to be prepared for living this life, for our akhirat, everything. What we typically don't think about is that phase when we are not living our full life and we're not dead yet. So in Quran, chapter 3, verse 186 says, every soul shall taste of death. Next slide, please. So dementia is very prevalent. 10 to 12% of U.S. population ages 65 and older has dementia. Lifetime risk of dementia from age 55 onwards is estimated at 42%. Women are affected more. Black adults are affected more, and ApoE4 carriers are affected up to 60%. And one thing about ApoE4 carrier individuals, their risk, it does not just increase the risk of dementia, it also increases the risk of several other diseases, including cardiovascular disease. Um, by 2060, we are going to have double the cases of dementia that we have currently, or we did in 2020. So, roughly 1 million people by 2060, what they're calling silver tsunami, is coming to us. Most commonly known dementia, when anybody talks about dementia, is Alzheimer's disease, right? Because most of the research is on it. That's kind of dementia is just thought that it's Alzheimer's. It is one of the most common types of dementia. About 60 to 80% of all cases are Alzheimer's, but dementia patients rarely just have dementia by themselves, dementia in itself. There's many other comorbid conditions that are not only contributing to the progression of dementia, but also their overall decline. Next slide, please. And, oh, sorry, the one before this, Jazakallah. So Alzheimer's disease by 2024 CDC data is the sixth leading cause of death in adults 65 and older. Um, if I had a magic wand, I would wish that anytime an adult, a physician, an NP, whoever the clinician is, diagnoses somebody with dementia, they sit down and they have a talk with them about what it actually is. Because even when they come to hospice with us, with me, they are still thinking it's just memory loss. Dementia is a progressive neurodegenerative disease, right? And that is what we need to educate each one of you. If you go and educate your circle, would be a huge service, because what that means is this actually degenerates the nerve, and that's where all the complications come in. I mean, memory loss, we can deal with that, right? But the neurodegeneration is what is causing all the complications, and it is a progressive disease. Um, as physicians, as researchers, as family members of dementia, we're always focused on curing. But the ground level reality of dementia is there is no cure. So we have to focus on the care part of it. And most common reason for deaths in dementia patients are infections, right? So when I talk about neurodegeneration, I'm talking about lost connections between brain and the physical body, which means that these patients and I'm talking about end stage dementia, right? When they are in their final phases of life, um, they have physical difficulty in swallowing, what we call dysphagia, which means that they're aspirating anytime they eat. Even when they're not eating, they're aspirating on their saliva, which is causing chronic pneumonias, chronic pneumonitis. They continue to have sepsis due to urinary tract infections because they're retaining urine because their body doesn't know how to urinate by itself like it has done all the life. Wounds because malnutrition has set in. They're not hungry, they're not thirsty, so they're not asking for food. They cannot swallow food. Pressure wounds happen because they're not moving. They're bedbound or they're chairbound. Falls and fractures are one of the most common causes of hospitalizations in these patients. And each time they go to the hospital, their baseline even gets lower than what their previous baseline was. And general overall decline to where they're just kind of existing in bed. And that's where all the complications are setting in. Next slide, please. So what I think, culturally as well, lack is advanced care planning. We are thinking, like I said, we're planning for this life, we're planning for our akhirat. We're not planning for the final phase of our life when we're between those two places. As the dementia progresses, they cannot communicate, right? So there's lack of understanding, there's lack of meaningful communication, and there's lack of decision making capacity. So every individual has a right to make the decisions about the type of medical care that they want to get at whatever phase of life. Consent is so important for all of the clinicians that are sitting here. But as the dementia progresses, the decision-making capacity is not there. So how we don't know what their wishes would be. So that's where advanced care planning is extremely important. It's not an event. It's not an one appointment with your lawyer or with your doctor. It is a process because it changes every time there's a new complication. You might think, you know, a year ago that, oh, I take me to the hospital every single time I get sick. But after third or fourth consecutive hospitalizations, that goal changes. There are people who come on hospice who are just completely sick of going to the hospitals because every time they go to the hospital, they come back with a new disease. Um, so basically, it's planning for future care based on a person's beliefs, values, preferences, and specific medical issues. It's not one size fits all. When you go to the lawyer, there's a very standard um, advanced care planning document. It has a very generic language if anybody has ever read it. So personally, I think the most important thing you can do in that process is appoint a surrogate decision maker, right? Because um, documentation changes, documentation gets lost. You might be in the hospital and nobody can find where those advance directives are. But if you have a person in your life who you've talked to about what your wishes are, um, he or she would be the best advocate at that time for you. And document that part because a lot of times, so all states have this hierarchy of next of kin or the surrogate decision maker that a person will have, and most of the times it's your spouse, and then your children, your adult children, and then your parents, and then your siblings, and so on and so forth. But if you want to appoint another person who you think knows you more than your spouse, it can happen, then that part you need to document. Otherwise, if anything happens and there's nothing written, your spouse and then your adult children, all that hierarchy kind of comes in play automatically. And those are the people who are going to be making decisions for you, whether you like it or not. Next slide, please. So different types of, so advanced directives are basically documentation of that whole process of advanced care planning. Multiple different types. Living will is a legal document. You usually go to a lawyer. It needs notary. It needs witnesses. You basically kind of line out everything um, and have it, in your record. Have it a copy needs to be with somebody, maybe your physician's office or maybe your lawyer's office as well. A competent person. Now, this is not once done and now you're done for the rest of your life, right? You may have done it 10 years ago, but now you're in a different place. As long as that person is competent and able to make their decisions, they can revoke and change their will. The second is durable POA. The durable part is important in this because durable means that it would automatically apply to every instance when you are in a position, temporary or permanent, when you're not able to make your decisions. For example, if you go to surgery and you're under anesthesia, you're not awake enough to make your decisions or let them know what you want. God forbid something happens. So the durable part means that POA or power of attorney kicks in at that time. So that's a really important document. Um, one thing that I deal with on a daily basis is surrogate decision makers are supposed to make decisions based on what the person would have wanted, not based on what they think the right thing is in that moment, or what their preference would have been. So that's a really difficult decision, and that's why it's very important to choose the right person to be your surrogate decision maker. Most, most, all these are very specific, state specific, out of hospital medical treatment orders. It kind of outlines, and a lot of times you'll see them when somebody's been admitted to the hospital and they're getting discharged, and a physician or I don't think advanced care providers can do this. A physician has to do this. Basically outlining like if they want CPR, if they want IV pressors, if they want antibiotics, hospitalizations, things like that. DNR is just one part of it. And DNR, there's a whole lecture can be given on DNR. DNR, which means do not attempt CPR in case the heart stops, does not mean do not treat, right? DNR, at least in my world, how I explain to my advanced dementia patients, families, and or people who have other kind of advanced illnesses is DNR does not mean do not treat. DNR means do everything within reason, which is reversible and treatable until the time of death is there, and at that time you allow natural death, right? So with DNR, sometimes even among physicians and healthcare providers, we don't do a good job of treating those patients who have DNR. Next slide, please. So two things I wanted to talk about care-wise when the dementia has entered its end stages. And typically those patients look like that they are not really mobile, kind of bedbound, spending most of the times in chairs, wheelchairs, beds, falling a lot of infections. Um, Palliative versus hospice. There's a lot of mixing up of these two types of care, although it's one fellowship, but the the scope is very different. Palliative is when the prognosis generally is in years, and I rarely, unfortunately, see dementia patients accessing this part of medical specialty. It is basically focused on improving quality of life for patients with serious illnesses by managing symptoms, and it can be provided alongside all the other curative options that are going on. Where patients really utilize palliative care is our cancer patients. Most cancer centers, most ALS centers, most MS centers have a palliative care physician on their staff, and cancer patients are very well familiar with this kind of medical care. Dementia patients, not as much. Next slide, please. So hospice comes into play when the prognosis is more likely than not 6 months or less, if the disease ran its natural course. And two physicians have to certify that they agree with this prognosis. Right, those are the dementia patients. Now, a lot of different diseases, qualify for that. Treat, metastatic cancers, end-stage ALS. There's a huge list of that. But specific to dementia, these are the patients, like I was just speaking about, not able to do much for themselves. They are dependent for most of their ADLs, which are activities of daily living. Like they need somebody to bathe them, to transfer them, to transport them, to dress them, to feed them. Um, they can either not speak much, or if they speak, the speech does not make any sense. They're not able to eat much. There's a lot of weight loss despite eating, trying to eat as much as they can. Wounds are not healing. There's recurrent hospitalizations, recurrent infections. So those are the patients that will typically qualify for hospice benefit. Now, like I said earlier, most, I would say over 90% of the patients will have other advanced comorbid conditions like congestive heart failure, COPD, other type of diseases along with dementia. Next slide, please. Hospice also gets, there's a lot of misconceptions about hospice, unfortunately. I think on the healthcare clinicians side, we also a lot of times don't do a good job explaining what it is, right? It's not, we can't just say, oh, there's nothing more to do, we're just kind of washing our hands off of you. It's not. It's that you are focusing on symptomatic management because there's no cure, right? Unfortunately, that's the reality for dementia patients. There is no cure. So when it gets to the point of where there's so much symptom burden, then the focus of treatment shifts from curative intent to palliative intent to basically manage their symptoms. Hospice also is very different in America compared to if you look at England. I don't know much about the other countries, but I've heard from in UK, it's actually a place, right? Hospice is supposed to be a place where patients check in. In America, it's not a place; it's a service. So over 80% of the hospice patients are living either at home or in a nursing home or and their assisted living, wherever they call home. 80% of the services are provided there. There are different levels of care based on the severity of somebody's symptoms. There are standalone hospice units for patients whose symptoms cannot be controlled in a home environment. And typically, it's an interdisciplinary team approach. There's a physician, there's nurses. It's basically a nurse-led model. They'll visit the patient every week or more than once a week and kind of manage the symptoms along with collaborating with the physicians. There's a chaplain, social workers, home health aides, volunteers, a bunch of different type of therapies. Um, so it's a whole team that is available for the patient and the family. Next slide, please. So these are some of the resources for advanced care planning. 5 wishes. It's actually a really comprehensive document, and anybody can do it. Some states require that to be notarized, some states don't. So you kind of have to see which state you're living in. But these were some really good resources to not only look at them ourselves, use them perhaps, but also give to our patients and see if they can benefit from them. Next slide, please. That's all I had. Jazakallah. Sure. Last slide, please. If you could just go back on it. Jazakallah.
Jazakumullah. So now we're going to move on to the men's side. Dr. Shah will be introducing our final speaker, Dr. Qamar Khan.
Assalamu alaikum warahmatullahi wabarakatuh. The third and final speaker for this session is Dr. Qamar Khan. The title of his presentation is Dementia and Delirium, Recognizing, Distinguishing, and Responding. Dr. Qamar Khan is an academic hospitalist affiliated with multiple hospitals across New York and New Jersey within the Hackensack Meridian Health and Northwell Health systems. He earned his medical degree from AUC in St. Martin and completed his residency in internal medicine at Hackensack Meridian Health in 2020. Dr. Khan currently serves as the local Tabligh secretary for the Central New Jersey chapter and is a member of National Public Affairs team. He also chairs the Waqf Arzi committee under AMA USA, a proud Waqf NO. Dr. Khan has been blessed with several Waqf Arzi opportunities, including serving at the Tahir Heart Institute in Rabwa, Islamabad, UK, and Nasser Hospital in Guatemala. He's also serving as one of the coordinators for the Fazle Umar project. Mashallah, he's an inspiration for all. Without further ado.
Jazakallah for the introduction. So I will continue on the grim topic. I've been asked to speak about dementia and delirium. Thankfully, Dr. Mateen has already spoke a little bit about dementia. It makes my life a little easier here. Allah states in the Holy Quran, and when I am ill, it is He who cures me. 55 million people worldwide live with dementia. By 2050, it's estimated that 139 million people will be affected. Ladies and gentlemen, these are not the projections of distant future. This is actively happening in our wards, in our floors. These are the realities of today. Delirium affects up to 50% of hospitalized older patients, and it is under-recognized in 70% of the cases. So it's very important to note that 70% of the cases are under-recognized, and this is where the clinicians can come in and be more observant and aware about these cases. 30 to 40% of delirium cases are preventable. These are not rare edge cases. They're in every floor, every specialty, every night on call, and especially happens at nighttime. So the way I did my presentation is I broken down into delirium and dementia. Initially, I'll speak about delirium, some of the causes, some of the pharmaceuticals, and then I'll progress to dementia and show some overlapping slides as well. So what is delirium? It's an acute disturbance of attention and awareness. It's very important to remember that it's acute and inattentiveness. So it happens in hours to days, it fluctuates, often worsens at night. It is reversible if the causes are treated. There are 3 subtypes: hyperactive, hypoactive, and mixed. It's important to note the hypoactive one because it is often missed and it is the most dangerous one. And it looks very similar to depression or fatigue, not confusion. So physicians may consult psych and have their input, but it's important to differentiate these two. Often I do come across these patients, and it usually happens on discharge when we're really trying to get the patients to rehabs or home, and we get a call that the patient's now altered, and we have to go assess the patient. And usually the questions that I tend to ask is, tell me your full name, and usually they get this right because they know their name. But the next question comes in about the date the full date, and who's the president. This, if they're not delirious, they usually laugh at this one. So, what are the big four culprits? These are the medications that we must be aware of because if the patients are on this, then we need to get them off. Number one is the anticholinergics, diphenhydramine, oxybutynin, just a medication for overactive bladder. Benzodiazepines such as Xanax, Ativan, these are the medications. But it is also important to remember that if the patient's on it for a long time, then we should not abruptly stop it because it can lead to benzodiazepine withdrawal as well. Opioids, these are another set of medications given for pain. And then other hypnotics such as zolpidem, these can also cause delirium. Some of the hidden anticholinergics are diphenhydramine, again, Benadryl. This is very commonly taken, so we must be aware that it's one of the medications that can cause delirium. And Tylenol PM, some sleeping aids, a lot of people take melatonin. These medications can cause it, so if they are on it, then it should be held. Overactive bladder, as I've discussed, oxybutynin, amitriptyline, these are medications for depression. Hydroxyzine, this is given for anxiety, itching. This medication can also lead to delirium. So now we'll progress to dementia. Here, the important differentiating factor is that it is chronic and a progressive decline in cognitive function. It does not happen overnight. This is a gradual onset, takes months to years. It progresses steadily and then declines. So it is also important to remember that it is irreversible and usually permanent. Now, just because someone has memory loss does not mean, they have dementia. You have to know the different types. The most common type, as Dr. Mateen had also discussed, is Alzheimer's disease, which is 60 to 70% of cases. Now, vascular dementia, this is someone who had a stroke and, gradually they have decline in their memory. And it's a stepwise decline. Sometimes they have one stroke and their memory declines, and then, a year later they have another stroke, and then there's another decline. Now, the third one is frontotemporal dementia. This is usually younger in onset, usually in patients with age 40 to 65, and there's a personality change. So, not necessarily a memory loss, but these patients will present very strangely. They'll have a personality change, like they'll have impulsive behavior, they'll start to, curse, or, there's a strange personality change which wasn't observed in the past. The fourth type is Lewy body dementia. And this one is also very important to differentiate from Alzheimer's because this one has visual hallucination. So it sounds very much like, patients coming in visual hallucinations. What do you first think of? You think they're probably schizophrenic or having some kind of a psych case. And the first thing we do is either consult psych or we'll have them started on antipsychotics. But it is important to differentiate because antipsychotic medications can actually worsen this type of dementia. So here are the drugs that are linked to dementia risk. Again, these are similar drugs to the ones that were discussed in the past for delirium. Just note that this is a cumulative use over 3 years, usually even longer. And, it's just the additive effect that can eventually lead to dementia, but these are observational, but it has been consistent. PPIs, this is very strange because this is a medication that a lot of the patients are on. Some of the examples are Protonix, someone with ulcer, they've been on it chronically. So it's important to just note that if the patients are on it, it is linked with dementia risk. So again, as I had stated, dementia is not just memory loss. There's a lot of clinical features. Some of them, it's very important to remember that amnesia, these are the 5 A's, by the way. Amnesia is number one. It's memory loss, especially recent events. They'll definitely remember what happened 5 years ago, but something they did yesterday or just a few hours ago, they'll have trouble recollecting their thoughts on it. For example, They won't remember if they left their keys at home, where their keys are, or they turned off the stove or not. And they'll just randomly walk off, go to streets, and forget their address. They've been living in the home for years, but they'll forget their address or their directions. So this is, the more recent events. Second is aphasia, word finding difficulty or reduced fluency. Third is apraxia, difficulty with learned motor skills. Something dressing, they've dressed all their life and now they're having difficulty dressing themselves. It's a red flag that it could be progressing to dementia. Fourth is agnosia. This is failure to recognize objects, faces, or places. You know, Sometimes you'll have patients with dementia, and they won't even recognize their family members. It's very distressing for the family members, um, but this is a sign of dementia, and we must recognize that. Fifth one is executive dysfunction. So this is planning, judgment, insight. This can also be impaired in patients with dementia. Again, the red flags demanding urgent referral is rapid decline. It's very important to note that. Um, Age less than 65. So patients who are presenting with age less than 65 and come in with these kind of signs and symptoms, it could be frontal temporal dementia. It could be something called Creutzfeldt-Jakob disease, CJD, autoimmune encephalitis that also presents with in earlier age. The third one is focal neurological deficits that they come in with. Gait disturbance, that's also key. They're having difficulty with their gait. Um, we may think it's something else going on and they'll have $1 million workup, but it's also a sign of dementia. Sudden onset, that's another sign. So, how do you tell them apart? Look at the onset, as we have discussed. Delirium, sudden, hours to days. Dementia is gradual onset. Course in delirium is fluctuating, often worsens at night. Steadily and stepwise decline in dementia. Attention, always impaired in delirium. That's key. That's almost pathognomonic for delirium. If someone's coming in with change in mental status and inattentiveness, then it is almost always delirium. It's usually preserved in dementia. Again, delirium is reversible, dementia is not. And causes, as we've discussed, are medical illnesses in delirium and neurodegeneration in dementia, so more chronic. And we'll discuss that in the upcoming slides. So what can we do for these patients? The 4 R's. Number 1, reconcile every medication. So we as clinicians, we're reconciling medications. If someone's coming in with altered mental status, we have to make sure they're not on some of these medications that can increase their risk of delirium, as we've discussed. Some of the over-the-counter, like Benadryl, if they're on sleeping aids, melatonin, 90% of them are on it. Number 2, recognize that the big 4, the flags, the anticholinergic medications, benzodiazepines that we discussed, opioids. 3, replace. So look for safer alternatives. For example, if someone's on Benadryl, you can replace it with cetirizine. There's no risk in that. Number 4 is reduce, taper slowly. As I had stated, never abruptly stop benzodiazepines, and as it can lead to benzo withdrawal. Instead, do a slow taper. So when do they collide? It's important to remember here that dementia is the single biggest risk factor for delirium. So someone who's coming in with the confusion and they have history of dementia, we may think, oh, their dementia is progressed. But we need to remember that delirium is actually, most common in patients who already have underlying dementia. So there's 5 times greater risk of developing delirium during hospitalization. Delirium accelerates cognitive decline. Each episode may be irreversible, and it leads to longer stays, higher mortality, and increased care needs. Sometimes, like I had stated, we're trying to discharge a patient, and now they're altered, and we start doing this workup, and they end up staying an extra few days until this is resolved. So what's the danger? It is easily attributed to the new confusion is easily attributed to the dementia being progressive, but it is actually delirium that we need to keep in mind. Always ask yourself, what has changed? What could be causing this? Some of the practical assessment tools. For delirium, it is CAM, Confusion Assessment Method. It takes 2 minutes. You can easily Google this and go through this with the patients. For dementia, as Dr. Mateen has also stated, MMSC, MOCA, these are screening tools that can be used for cognitive impairment. For delirium, remember these causes. It's pinch me mnemonic, pain, as she had stated, uh, someone who's in severe pain, perhaps from cancer or other causes that can actually lead to delirium. Infection like UTIs, pneumonias, nutrition, lack of nutrition can also cause this. If they have catheters, that can lead to urinary tract infections and also cause delirium. Hydration, all these patients, they're usually elderly and with lack of hydration can lead to this. Medications, as we have discussed, and environmental causes as well. So delirium is largely preventable and treatable without medications. Orient the patients, very important. Always orient, use non-pharmacological methods before going to pharmacological ones. Orient them, restore their sleep-wake cycle. We had a talk on circadian rhythm this morning, so this is where this comes in handy. Make sure they're sleeping at night and they're awake in the morning time. Mobilize them early. Use their, if they use glasses and hearing aids, then definitely provide it to them. Um, Treat their infection, pain, constipation, and review their medications. I will end with this slide, and I also have 30 seconds left, so I want to take some time and discuss this slide. Holy Prophet Sallallahu Alaihi Wasallam Rahmatullahi Alameen has stated that show mercy to those on earth, and the one above the heavens will show mercy to you. You know, our patients with dementia and delirium are among the most vulnerable. They cannot always speak for themselves. We must be their voice. Their confusion can be frightening. Presence and calm are medicine. Family involvement is not optional, it is therapeutic. Always have their families involved. If they're not available in person, have them speak to their family members. It can go a long way. In Islam, caring for the sick is an act of worship. The dignity of every patient is non negotiable. With that, I'll end. Jazakallah.
Jazakumullah. Now we will have a little bit of time for our audience Q&A. So maybe we can start with the women's side, if that's okay. Is there any
Please go ahead.
questions?
What are the lifestyle things we can do to delay dementia before it starts? I'm not talking about the medication, but even before the medication. What are the risk factors that causes early dementia?
Anyone want to?
I can take that. So, dementia, as I mentioned, it's always more than one thing going on. For dementia types like Lewy body dementia or frontotemporal dementia, there is no prevention, right? It is unfortunately going to happen. Strong genetic component but for dementia. Like vascular dementia or mixed dementia, like almost 60 to 80% of people have mixed dementia. It's your lifestyle. It's like we're beating the dead horse so many times. Diet, exercise, keeping the mind active, avoiding the smoking. So, if somebody has diabetes, high blood pressure, high cholesterol, high risk for heart attack, strokes, all of these things are also affecting the brain, just like they're affecting the heart. And that's where your dementia risk is coming in as well. So controlling these modifiable risk factors is extremely important.
Okay. Any other questions on the women's side? We have one.
So, Jazakallah, excellent presentations by all the speakers. So, two questions, one for Dr. Mansoora and one for Dr. Malik. So, for Dr. Mansoora, what's the best way to consume creatine? And is there any evidence of strong interaction with caffeine? And then, question to Dr. Malik is there any strong evidence of association between sugar intake and dementia?
Jazakallah for that excellent question. So, creatine, it really depends on the most soluble form. I'm not sure which one that is, but you really have to see if there's any other additives in the ingredients. So make sure that it's not, fluffed up with other stuff. I'm not sure if there's any interaction with caffeine. I know that whenever you do take in caffeine, there's vasoconstriction, and that it stops your absorption for a lot of your vitamins. So I'm sure that creatine would have a very similar effect. I'm guessing I wouldn't take them together. No, Jazakallah.
So the sugar and dementia. So anything that's pro-inflammatory, and sugar is high up there for causing inflammation, is going to increase your risk of not only just chronic inflammation but other all of these other diseases. So from that perspective, absolutely yes. Direct correlation, if these risk factors are not there, not that I'm aware of.
Oh, we have one more question.
Um, Aisha Ahmad. Sorry, this is not a question, it's a comment. So I just want to reiterate to all the physicians and the advanced practitioners that we are often taught that delirium is acute, reversible, short-lived. But there's a rising body of evidence that sometimes delirium can last weeks and months, and it can almost coalesce into a new neurocognitive illness, which can happen over weeks and months. So the mantra we're taught in medical school that it's always acute, short, reversible is not always true. So it's really important to prevent delirium because it really has bad prognosis, in some ways worse than cancer.
Would you like to add?
So absolutely. One more quick thing that I've actually experienced in my patient population, the cognitive impairment from an acute episode of delirium actually can last up to 6 or more months. And people, to a point where people actually start thinking they have dementia now. So absolutely very important to prevent.
Jazakumullah. Oh, we have one last question, I think. This will be our last.
Assalamu alaikum, Zakala, for the excellent presentation. So my question was that is there any herbal supplement that can help us, or homeopathic medicine that can help us to prevent, or if it happens to slow down? I know that in severe glaucoma patients, we sometimes tell them one of the herbal supplements, the Chinese supplement, in a low dose, because it slows. There's a research that has been published that it slows the decline of optic nerve function, and we know the optic nerve is connected to your brain. So Chinese take it very regularly, but I don't know whether I do it in a very low dose in my severe glaucoma patients, but I'm not sure. What's your opinion?
Who would like to answer?
Jazakallah, I think we have a minute left. So if men have any questions, I'll quickly. All right. I'll bring the mic to you.
Quick answer to that. Not any research that I'm aware of. Now, there's all this, anti-inflammatory kind of supplements, and ginger and garlic and cumin, not cumin, sorry, turmeric. Sorry, that's what I'm thinking. People do take that to lower inflammation. I'm not aware of any research that lowers the risk of that. Any of this lowers the risk of dementia, unfortunately, but definitely lowers the inflammation part.
Ji, Assalamu alaikum. This is Dr. Harun. I just have a brief question. How would you differentiate delirium with encephalopathy? Because that's always a confusion whether you call it encephalopathy or you call it delirium when these patients come in the hospital setting or in the nursing home settings.
I think he'll answer.
Just for that question. Well, encephalopathy, it just means, there's so many different types of encephalopathies, right? There's metabolic encephalopathy, there's toxic encephalopathy, there's so many causes, there's drugs that can cause it, there's infections, urinary tract infections, pneumonia. So all of these things obviously can trigger delirium also. So like I had stated, the way to differentiate is in delirium, it is going to be acute in onset. It occurred. Encephalopathy, that's something that also it is acute, and once the underlying cause is improved, then the patients will back to baseline. So yeah, it is. You can call it that because obviously it's more of like a coding thing. Once we document, right? If patients has delirium, they're altered, so we can call them acute metabolic encephalopathy secondary to infection or drugs. So it could be overlapping in that sense if that's what you're asking. Jazakallah.
Any other questions on the men's side? No?
Okay.
Oh, you have a comment. Okay. Last comment, and then back to you, Dr. Zirvi.
So the question was prevention of dementia, and one research which I was involved in shows that vitamin A deficiency can lead to dementia, and replenishing vitamin A restore dementia, age-related dementia.
One more. Last one, I promise.
So my question I had is for myself. With respect to drugs that cause delirium, when there is a episode of delirium, but then there isn't any alteration in drug use after that medication was prescribed and the delirium goes away with additional use. First of all, do you see that? Is it just an initial priming of, for example, the receptors and central nervous system to the drug and it causes a delirium, but then there's a stabilization where the medicine holds, takes, is effective, and the delirium disappears? Or is it that in every instance, persistent use of that medication will continue to prolong the delirium?
Jazakallah, that's a great question. What I've seen is that usually if the patients are on those medications, they will be stabilized on it, and everything will be okay, and they would continue to take those medications. But sometimes it's the other causes that would come into picture, like some infection or pain or something else that occurred, and because of that reason, that multiplier would cause that patient to go into that delirious state. So in that case, until that infection or underlying culprit is resolved, I would take away that medication that they've been on, and that would help overcome that delirious state, and then eventually they can go back on it, right? So such as benzodiazepines that I had discussed earlier, this is not a medication that should be taken off abruptly, so they should be slowly tapered or continued. Sorry?
Jazakumullah. I think we'll just have to wrap up. Jazakumullah to all our panelists for their
So
fruitful-
yes, I'm not sure about some of the drugs, but I'm sure there are some drugs that would cause it. I'm not aware of the specific ones at the moment. Jazakallah.
Back to you, Dr. Zirvi.
Okay, thank you. Jazakumullah to all our panelists for generating this great discussion. Now to the announcements. Just a reminder that there will be a student networking and dinner from 6:30 to 8:30 in the dining area. And I was told Salat should begin around 9 o'clock in the basement. Thank you.